So, evening everybody. My name is Larry Kramer. I'm the President and Vice Chancellor here at LSE. It's my pleasure to welcome both our live audience and those who are joining online to this very special event hosted by LSE's Department of Health Policy. So, no one would want to say that there's anything good about the COVID-19 pandemic. But it did, as it unfolded, provide a forced natural experiment for a lot of pandemic preparedness and response policies. We were able to see what worked, what didn't work, who was served or disserved by policies, and what kinds of downstream effects flowed from particular policy interventions elsewhere in the health system and in society at large. We're now beginning to really analyze and understand the lessons of all of that. So one important audience for those lessons is policymakers who are epidemiologists or natural scientists, who generally prefer talking about data over addressing more qualitative issues of policy nuance and design. It's critical, though, that we engage that audience, especially now, because the entire architecture of the global health security system is currently in flux. Governments everywhere are reviewing their pandemic preparedness plans. Having created a European Health Union, the EU recently increased its role in health security. Likewise, Africa's Centers for Disease Control have done something similar. At the same time, governments are working to negotiate a pandemic treaty to share data, ensure vaccine equity, protect healthcare workers, and build robust health systems, among other things. At the global level, the World Health Assembly this past summer amended the international health regulations and made concrete commitments to completing negotiations on a global pandemic agreement within a year. Our guest tonight knows as much about these subjects essentially as anyone alive, and we're thrilled to have her with us to discuss them. Rebecca Katz holds joint appointments at Georgetown University's Medical Center and School of Foreign Service, where she also directs the Center for Global Health Science and Security. She earned her MPH from Yale University, her PhD at Princeton University, and she's a member of the Council on Foreign Relations. From 2004 to 2019, she was a consultant to the U.S. Department of State, working on issues related to the Biological Weapons Convention, pandemic influenza, and disease surveillance. She returned to the State Department in January 2021 as a senior advisor on the global COVID-19 response and global health security. In 2019, Professor Katz co-convened the first international scientific conference on global health security, bringing together over 900 participants from around the world to form a community of practice. We're thrilled to have her with us tonight. We'll have her come up here and speak. After Professor Katz speaks, Dr. Claire Wenham from the Department of Health Policy will facilitate a Q&A with her and with you. For those of you here in the theater, when we get to that, please just raise your hand. Someone will bring you a microphone. When Claire calls on you, give us your name and affiliation before posing one short question. The online audience can submit questions through the Q&A feature. I'm talking to them. Through the Q&A feature at the bottom of the screen. We'd ask you also to let us know your name and affiliation, and we're particularly keen to hear from our students and alumni. Lastly, for social media people following the conversation, the hashtag for today's event is hashtag LSE Events. The event is being recorded and will hopefully be made available as a podcast, subject to no technical difficulties. So with that housekeeping done, it is really my pleasure to invite Professor Katz up here to get us started.
All right. Well, that kind of shows up, but not entirely. Okay, so I'm really, really delighted to be here. And what I'm going to do tonight is give a little bit more detail of what's happening in the space of global health security, but then try to dive in on some of our research and some of the work that I'm pretty excited about and hopefully will be of interest to you as well. So I run a center, the Georgetown Center for Global Health Science and Security, which, am I not loud enough? Okay, better? Maybe better? I'll have to literally stand right in front of it. So what we are trying to do is provide the scholarship to try to stop the next pandemic. We work to mitigate threats posed by outbreaks, other public health emergencies, trying to enrich the evidence base for informed decision-making on how to prevent, detect, and respond to, and ideally to recover. So, just give me a second, I'll get used to this. Within the center, we have actually a series of labs, but in addition to directing the center, I also run the Health Governance and Diplomacy Lab. And this gives you a sense of some of the work that we're up to. We curate data on policies, laws, regulations that are relevant to public health emergencies and infectious disease threats, regardless of origin. We try to assess and analyze how pandemic preparedness response policies, laws, and regulations impact health outcomes. We try to engage in scholarship around global governance regimes for health security. We track the flow of financing and develop costing tools related to this space. We work on metrics, guidance, and then we try to train the next generation of global health diplomats. So just that. And I also want to note, it was mentioned in the intro, I've also spent about 20 years supporting the US Department of State. Quick disclaimer, I am here in my academic capacity and in no way representing the Department of State, the United States government, anybody else for that matter. But in addition to doing all this work on the academic side, I think many of us who work in this space got brought in to work directly with lots of different decision makers throughout the pandemic. And I had the opportunity and the privilege of supporting not just the US government, but also mayors, governments, international organizations, private sector entities, Las Vegas casinos, you name it. I got to help write the COVID safety plan for the Las Vegas Strip. Blows your mind. And also, I also have the privilege of being the American on the technical advisory panel for the Pandemic Fund, in trying to help build capacity around the world. So my plan today is, again, a little bit on what is global health security, what's happening, fastest review ever of some of the kind of the highlights in this space. I think we have some other experts in the room who will no doubt ask really difficult questions that I won't be able to answer. Talk a little bit about financing. I'm not going to talk about really important areas of health security like medical countermeasures, research and development, supply chain. These aren't the things that I spend most of my time on, so I'm happy to talk about them in the Q&A, but if you're waiting for that slide to come up, you're not going to see it. And then, again, go into some of my own research. So first, the entire world witnessed firsthand the strengths and weaknesses of pandemic preparedness and response and health security around the world during the pandemic. It was very clear that there was a need coming out of the pandemic to build stronger, more robust architecture that was equitable, more transparent, accountable, one that both protected global economies and saved lives. I'm not loud enough.
Momentary break and put on a lapel mic.
Okay.
I'm not picking up the sound, especially for the online audience.
Do you like hum? Sing? Easy enough? Sure. All right. Is that better? Okay.
Try now. Go ahead.
I'm testing. Do I keep talking until somebody gives a thumbs up?
It should be fine.
Okay.
This one will be in use. Okay.
Yep.
That's brilliant. Thank you.
All right. So I don't have to lean over awkwardly anymore. All right. I'm not tall enough to stand behind the lectern and see people in the front row, so you stare at the slides. All right. So anyway, we were coming out, and it was very clear that we needed something better. And what was that something better? Well, the goal was a system that would prevent catastrophes, that would be able to detect a public health threat early. Oh, I just got louder. Okay, somebody's going to fix audio while I keep talking. Okay, something that would detect those public health threats early, respond rapidly, effectively through early warning, coordinate response, containment strategies, and that would include that manufacturing and distribution of medical countermeasures. And noting that doing all this requires global health security is a complex international political problem. It's not just a technical issue. And that a lot of stars actually need to align to be able to have a functional system to, again, prevent, detect, respond, and recover from those biological threats. Now, there's a lot of ways to approach this. And on the policy and governance side, there is, I'll use the word complex again, there is a complex web of governance tools for emerging infectious diseases, ranging from international agreements all the way down to local level implementation activities. And a long history of trying to create some of these international agreements. Now, one of the challenges is that these governance frameworks lie along a continuum. Is it okay if I move? Nobody's going to yell at me. Okay. So you have your norms and standards and your international governance at the 50,000-foot level. Sometimes you're having more and more regional agreements. You then have national level strategies, policies, and regulations. And then you have subnational policies and implementation. And you have this in all areas of any kind of area that you're trying to do global governance for, but it's even more pronounced in the public health space just because public health is so local at its core. So trying to connect all of these things is the goal, but it's also usually pretty broken, and it doesn't always connect. And in fact, there's the people in a local community may have no idea of whatever international treaty has just been agreed to and don't always see how it connects to their lives. But that being said, there are a lot of international agreements in this space. Hold on, wait a second, I pushed the wrong button. Hold on, okay, there we go. So we did some work actually in 2011 and then redid it during the middle of the pandemic to try to count how many international agreements there were. And we ended up finding, this is work we did with Kaiser Family Foundation, we found that there were over 70 multilateral agreements that are in some way related to health. And over 50 were in some way utilized during the pandemic. Now, getting your head around, so now if you're trying to go back and figure out how do we global governance of disease, well, we're now dealing with a really large number of international agreements that sometimes talk to each other, sometimes don't. So as I'm having technical issues, I will get there. I literally keep pushing the wrong button. So as part of this effort to try to strengthen our global architecture, one of the things that was done was to take a look at these international agreements that we had. So we've been trying to look at them, discern what needs to be better, what's missing, if what we have already is actually fit for purpose given the world that we're living in today and the lessons we've learned during the pandemic. And this exercise led to an effort to update, some of you were involved in this, the international health regulations, amend the international health regulations, which is the existing international agreement that's supposed to govern detection, assessment, reporting, response to these public health emergencies of international concern. And this process brought forward a huge range of proposals for updating language that eventually came down to a really discrete number of updates that were approved just a few months ago on June 1st. It's pretty weedy. The updates are not very sexy when you think about the world of new treaties and exciting stuff. And they may have the potential to be really important to how outbreaks are governed. And honestly, they're being tested as we speak, even if they haven't officially entered into force. And these are, the changes made were around issues on how we define a pandemic, how do we do coordinated financing. There was language on those medical countermeasures, or they called it health products, and then figuring out a new implementation monitoring process, so similar to the COP that we have in the climate space. There are parallel efforts underway to adopt a brand new agreement, but it is tripping over some of the most well-known challenges in global health governance, including something called access and benefit sharing. There's issues of viral sovereignty. How does one actually operationalize One Health? Happy to come back to this later, but I will say I am less optimistic than some that this will land somewhere that actually makes the world safer. Really hope I'm proven wrong on that one. But it is a complicated process. I think the other thing that's happening right now is that like all of the international organizations and all of the international NGOs that participated in some way or shape or form in the COVID response are doing a bit of rethinking to figure out what their long-term role in pandemic preparedness and response might actually look like. And asking some hard questions on whether their equities actually match their authorities and their funding. And sometimes the answer leads them to make some changes. What the world asked of the World Health Organization did not match how the world funded the World Health Organization. And so how do we fix that? So there are efforts underway to figure out how to incrementally change the way that WHO is financed, to think more operationally about how at the international organization level, organizations come together for One Health. Given that most emerging infectious diseases are zoonotic in origin, so your spillover events from animals, the events themselves are subject to an ever-changing environment and the climate crisis. We really have to be thinking about the animal, human, environment factors together. This is kind of first principles of global health security. And philosophizing about it is great, but operationalizing One Health is what's really needed now. So there's efforts underway to try to strengthen the relationship between what they call the quadripartite of the World Organization for Animal Health, FAO, and UNEP along with WHO. But that's, again, slightly easier said than actually done. And while all this is happening, there's efforts underway to improve the metrics that are used on how we measure how well the world is doing in building their capacities for preparedness and response. No metric is perfect. And there are some entities that are very committed to the imperfect ones. But there are multiple efforts to do some rethinking, including Lancet Commission, and work to figure out how do we come up with more accurate ways to measure capacity using the idea that what measures gets done. So, and then, and whatever metric you use, it is very clear that there is a tremendous amount of need that is necessary for capacity building around the world, and there are not sufficient resources devoted to it. One of the things that emerged out of the pandemic was a G20 report that led to the creation of the Pandemic Fund, which is now housed at the World Bank. It needs hundreds of billions of dollars, currently has closer to $2 billion. The asks from around the world are robust, and we'll see what happens. Hopefully the fund will continue to grow and to try to meet those global needs, but it certainly can't be the only solution we have. And while all this is going on, you also have nations around the world that are reorganizing. They're trying to better address health threats in the future. In the United States, on August 1st, 2023, they launched a new Bureau of Global Health Security and Diplomacy in the Department of State. Ministries of Foreign Affairs are traditionally organized around like regions, right? You have the Russia desk, you have like the Africa desk. I mean, so that's how MFAs are typically organized. So to have MFAs start to rethink how they're organized around the transnational threats of health and climate are kind of a really big deal. And in March of 24, there was a new foreign ministry channel devoted to health security that was launched. So there is now an effort underway to facilitate communication from MFA to MFA around the world. The other thing that happened in the United States is they launched a brand new office in the White House, the Office of Pandemic Preparedness and Response Policy. US Congress forced them to do this, passed a law saying it had to exist. And this office itself has a bit more of a domestic focus and is still trying to sort out how it works best with the National Security Council that deals with international threats. But nations around the world are doing similar things, right? So Japan is reorganizing and about to launch a new kind of Centers for Disease Control. Australia is launching a new Centers for Disease Control. The UK is reorganized to deal with health security threats. You have these new hubs for disease surveillance activities that are popping up around the world. And you have the rise of these regional public health institutes, regional CDCs. So these are just some of the things that are going on in our world of global health security governance right now. But all is not well in the world. We continue to see outbreaks. We are currently in the midst of a new declared public health emergency of international concern for Clade 1 Mpox. In the US, we are dealing with H5N1 and some really just kind of head-scratching amount of virus that is circulating in dairy cows. In the Americas, we've got dengue, we've got oropouche. We have Marburg that is going on right now in Rwanda, although the latest news from Rwanda today is that the outbreak seems to be going in a positive direction. So that's a really good thing. And if you just need to be more anxious in general in your life, I can happily point you to websites where you can track the hundreds of outbreaks that are happening right now. And specifically, all is not well in the United States. In addition to the ongoing H5N1 outbreak, we also have foodborne, waterborne, vector-borne, vaccine-preventable disease, serious challenges that are challenging both infrastructure and the inability to actually fund response to these threats. And some not so fun facts from the US up here on this slide is that at this point, approximately 80% of counties in the United States do not have an infectious disease doctor. Approximately 75% of local health departments do not have an epidemiologist. There are about 50% of counties in the US, equating to about 2.5 million people childbearing age, do not have access to obstetric care. There are approximately 62 beds in the entire country that can handle a viral hemorrhagic fever patient, and there is not great system in place for patient transport between those spaces. And we are now dealing with efforts coming out of the pandemic. There are states which didn't love the fact that the executives of those states, the governors, were able to have as much authority they did in emergency response to the pandemic. They didn't like that a governor could issue a stay-at-home order. And so what is happening is that there are, I believe, 100, 200 bills. There's a lot of effort right now in certain states, or at least half of them, to strip those authorities from the executive branch of the state and put it into the legislative branch. Okay? But from an emergency response perspective, that's going to slow everything down a lot and make it really hard to respond to a crisis. We are also facing, as everyone else in the world is, an extraordinarily large amount of mis and disinformation that just makes everything harder. So there's a lot going on. All is not well. I'm a lot of fun at parties. And we are deep into the neglect part of the panic to neglect, the panic to neglect cycle that we have in global health security. But we know, or at least we have a really good idea, informed by our past experiences, of the questions that we think decision makers are going to ask during the next public health emergency. And we know that at least some of them are answerable. So that's what we're trying to do. So what I'm going to use the rest of this talk to do is tell you about what we're trying to do to try to contribute to the evidence base in this space. Now, for over a decade, we have been curating data in global health security. If you are online, on your phone, on your computer, I invite you to play along. If you're not, somewhere write down this website, because if you are a student, there's about, there are dozens of dissertations sitting in this data. It's kind of insane. I just want to note, I spent a lot of time over the last decade working with the team to build really pretty websites. I don't know how much longer I'm going to keep the websites going. We'll maintain the data. So check it out now, and then later check out our GitHub. So everything will always be downloadable. And what I want to do is show you some of the projects and these curated data, and then save enough time to talk about our AMP EID project. So since 2016, we have been curating a data set that has been tracking the flow of international financing in global health security. About $165 billion we've captured that's been dispersed for capacity building and preparedness activities between those years. We not only track it, but it's also coded to, for those in the space, to the IHR-JEE indicators. So you can examine exactly how a country was doing by those internationally recognized metrics and how much funding and from whom they were receiving to build capacity in that specific area. We also tracked over about $76 billion that was provided to the different public health emergencies of international concern as part of the response. This doesn't include the Clade 1 MPOX response because we wrapped up the data set in 2022. But again, a lot of information's in there and really invite you to play with it. And in part because we haven't actually done that much analysis. We've published some descriptive papers, and we've also done a little bit of analysis which actually found an inverse relationship between the amount of money by international donors that were going into building certain core capacities and sustained capacity over time. Now, I sat on that for 2 years before we published it because I was really worried about what that narrative would look like. What it is actually is proving empirically what we've always known anecdotally, which is if a donor goes into a country and says, I want you to build laboratory capacity, or I want you to build a hospital, and the recipient country is like, well, that's not really my priority, but sure, I'll take your money. That doesn't get sustained. So I felt a lot better about the paper when I realized that there was actually a really strong narrative around the importance of having a collaborative dialogue and setting priorities and working together. So that's our, that's on the tracking the flow of financing. Staying on the theme of money, in addition to tracking what others have spent, we've also spent a decade plus building costing tools. We built a tool to help nations cost their public health infrastructure requirements under the international health regulations. In about an hour, a country can get a rough order of magnitude estimate of what it would cost for them to get from their current level of capacity to the internationally recognized standards of what they need to be able to prevent, detect, and respond. Rough order of magnitude. We put it up on a website. It's a pretty website, but it's linked to the old metrics. At this point, this tool now has almost 1,000 different lines, and you can go to the GitHub and you can download it all. And they are tied to the latest set of WHO's metrics, the JE 3.0. What we've also now been doing is working on curating a database of all the actual costs identified in countries as they go through it's called the NAPS process, the National Action Plans for Health Security. So they're now kind of complementary data sets. And using this tool and using that early iteration of it, the team was able to calculate in 2021 what the global costs would be over 5 years to get every country in the world up to what's called level 4. So the lowest tier of what is required under the international health regulations. And we came up with a number that was about $124 billion. That sounds like a lot of money. And it's a huge amount of money in public health. It's not a lot of money if I'm thinking about this as a security threat. So 124 billion, and that number didn't include the 60 to 80 billion of global goods, of what it costs for research and development, manufacturing, supply chain of those medical countermeasures. Now, fun. In the subsequent years since we did this analysis, those kind of the latest set of metrics have changed a little bit. They've added things like more healthcare workers, more like access to care, some more requirements on the subnational side, infection prevention and control, things that we kind of learned during the pandemic. And we haven't published it yet, but the team's been working on it, and our numbers now jump to about $300 billion of need. Now, if you remember, the pandemic funds got $2 billion. So it's a lot of asks, which then make you think, okay, there's only so much money in the pie. We really need to be a lot smarter about how we're spending those resources that we do have. So other work that we've been doing is, and this is some work with the Global Fund, is where we analyze budgetary data, not expenditure, budgetary data, in trying to figure out what is the actual overlap between things that build your, we'll call it the horizontal system, so your laboratories, your surveillance, the boring stuff that's the backbone of public health infrastructure, and what groups like the Global Fund for AIDS, TB, and Malaria are spending to fight vertical disease challenges. And we've looked at this upside down, backwards, and this going this way, and it turns out to be about a third. So there's about a third of the things that are in health security that also strengthen the ability to fight HIV, TB, and malaria. There's about a third of the stuff in the HIV, TB, and malaria programming that will also strengthen your horizontal system. That's important, right? It's not everything. Purchasing insecticide-treated bed nets for malaria is really important, but that's not going to solve your Ebola outbreak, right? So you got to actually be very thoughtful about what it is, but then also think about what those opportunities are for where there's intersects between these horizontal and vertical programs, so you can commit to, say, common platforms when it's possible. The other thing that we've been doing is spending a lot of time thinking about subnational governance. And we have been working on it for years prior to the pandemic, and then rushed to get it out the door in March of 2020, creating kind of a rapid urban health security assessment tool. We've also now published 2 edited volumes. One was pre-pandemic, the other post. These rank somewhere in like the 7 to 8 millionth of top purchased books on Amazon. So they're not bestsellers, but if you are interested in cities and the role of kind of urban decision makers in responding to disease, I highly recommend them, and because the chapters themselves are written by the city officials. And so it's their kind of firsthand perspectives. Okay. More stuff. Let me talk. We also have been working to curate data on historical information that could also be used in other analyses. So the only official documentation of an outbreak is the World Health Organization. They publish something called the Disease Outbreak News. It's prose, and it gets stuck on a website or in PDF. That's great, but that's not usable if we want to actually do analyses with that. So we've made it machine readable, and you can hop on GitHub and you can download it. And so we turned that into a data set and done some descriptive analyses on it. But the other thing that we've done at the same time is we basically built an online textbook. It's called the Georgetown Outbreak Activity Library, or GOAL. This is a nod to me being a soccer mom. So what we did was we captured about 170 plus activities that happened during an outbreak. You can go on to here, it's organized by different categories. There's case studies. You get you get for each one of the activities, like which of the categories it's in. Sometimes it's in multiple. Which phase of an outbreak response you're going to find it in, and then if it's relevant to different types, like is it something that would be relevant in a zoonotic disease event, deliberate, permissive, non-permissive environment, and with references to be able to go and look up more information. And then what we did we just published this in April, is we took all that information that was designed for our colleagues working in public health emergency operations centers around the world, and we turned it into a book for the general public. I love this book. We spent a lot of time on it. If you have relatives that have asked you questions around, like, what's a case fatality rate, or things that came up during the pandemic, this is great. It explains it to everybody. This is not hard stuff. We just don't teach it till grad school. So what we try to do is explain it to anybody who might be interested. There's about 120 case studies in this, and again, illustrated. It is slightly higher on the Amazon ranking, not that much more, but it's niche stuff. So all this is really neat, but the coolest of all is being able to have all this data so we can start to do some really cool analyses. This is a paper where first we proposed a taxonomy for the different types of outbreaks at the start of an event. Because you don't always have full information, you might go in 18 different directions. But you need to start with something. So you need to figure out what kind of event are you dealing with. And then we were able to combine that data from those 40 years of outbreaks with all those activities that we captured in the Outbreak Atlas. And the key finding here is that response to most kinds of disease outbreaks relies on the same set of core activities. Now, this is why this is important. If I'm advising a decision maker and I'm telling them that there's an emerging infectious disease event going on in their jurisdiction, I don't know what's going to happen, but I can say, listen, I'm not sure what direction this is going to go, but I do know that no matter what, you're going to need to do these 20 things. It's actionable, and with enough time and resources, we can actually probably even calculate the opportunity cost of not taking those decisions, which will then greatly help that decision maker figure out where to expend resources and political capital. So again, we can do this. We can provide information that can be used by those decision makers. Which gets me to policy epidemiology. Why am I even here? What's in the title of this talk? why do we spend so much time curating policy data? Like, why are we doing this? Because we have to. Because in order to make an informed decision using evidence, we need to first start with our denominator data. So I want to know what policies are out there that govern an emerging infectious disease in an outbreak response. Then, once I know what actually exists, I've got to figure out what's being actually implemented, where and how. Once I've done that, and only once I've done that, can I figure out, is the implemented policy effective? Does it save lives? And then if I can do that, I can get to this last piece. Now I have information that I can provide either directly to a decision maker to arm them with, good decision-making power, or I can also dock it into forecasting predictive models, which I can't really do until I know if I have an effective policy. So let's take wet markets. When you talk about spillover events, people like to talk about wet markets. Wet markets are the problem. Well, it turns out only about 6% of zoonotic spillover events are linked to a wet market. And what nobody's ever done is figure out, okay, let me look at where those 6% of events are and whether those are happening in countries that have implemented policies that, say, separate species in a wet market, right? So again, we can get really specific and really tight so we can take better action. So let's do this. So we started with something we called COVID AMP, analysis and mapping of policies for COVID. So during the pandemic, in real time, with 108 students working with me, we coded 50,000 policies, each with about 65 metadata. So again, those of you looking for dissertation topics, it's all sitting in here. And a whole range of policies. So we captured data on economic policies, housing, physical distance, travel, vaccines, enforcement, military mobilization, and we also captured the actual text of the policy itself. And you can go in and read the whole thing. So you can do your own natural language processing on it if you want. And you can use the data in two ways. So one was for kind of these long-term analyses, so you will all write dissertations and tell us what works and what doesn't work. The other was for tracking in as close to real time as we could the policy response to new twists and turns in the pandemic. So here's some work we did tracking the travel restrictions over a 15-day period when Omicron emerged. But if I take all this COVID data back to that policy epidemiology framework, so COVID AMP was our policy surveillance, what was out there. Then we had to figure out what was implemented. So I could identify all the stay-at-home orders that were being issued, but then we could look at things like mobility data to see if people actually stayed home. And once you knew that, then you could figure out you could then look at effectiveness. So you had to pick a jurisdiction that people actually didn't go out and abided by the stay-at-home orders. And then you could figure out if that implemented policy actually saved lives. And again, if you know all these things, you could then help guide the decision maker through a crisis and then integrate it into your forecasting models, which is stuff that we were also trying to do in real time. So we figured we should be looking at a bunch more policies related to more than just COVID. So we were going to look at all the threats of emerging infectious diseases. There currently exists no comprehensive database of health-related policies that can be incorporated into analytical models. Why? Well, doing this requires in-depth expertise. It is super labor-intensive. It is difficult to incorporate prose into categorical or continuous data that can then be used in analysis or epidemiologic modeling. And these are all really important considerations, but they're not roadblocks. So we moved forward. We also went back to this notion, this figure, to figure out what level we should be looking at. And to start, we decided to go with that highest level of international agreements, but then jump to looking at those national policies. And maybe someday, if money rains from trees, we'll do all of it. Oops. But we did start with the international agreements. We started with 12, structured some data around the agreements, membership timelines. None of this is novel, but we used the international data to force us to organize our data structure and make all the hard decisions around, what do we count as a country and how do we code it. So we did this first. And then we started to prioritize sets of topics to explore. So if you come to our really crappy offices, our walls are lined with whiteboards looking at all the things we want to do next, but haven't gotten around to yet. So, but this is what we've done already, right? So we've already completed and available online, and you can download it and play with it. Antimicrobial resistance and WASH, AMR and AG. Okay, these are all national level policies. Access and benefit sharing, childhood vaccination, general policies around vaccination, trade and intellectual property rights. We've actually got our IPR coder here. We have a couple more topics which are done and will be posted momentarily. That includes jurisdictional authority for quarantine and isolation, community engagement, risk communication, and military engagement in outbreaks, and then hopefully we'll have the biosafety and biosecurity work done in the next couple of months. And then we've got, again, a really long list. It's marking all the walls of stuff we want to do in the future, and that includes some highlights include AMR prescribing, medical personnel deployment, that question about wet market regulations, other zoonotic controls efforts, and so we've got all these lists, and at the same time, we've also started efforts to look subnationally within the United States. So we've been looking at childhood vaccination policy, patient transport, quarantine, surge capacity for patient care. And this is what we do. So this is the methodology that we follow for all of our work. And for each topic, we develop a standard methodology for scoping, identifying how we're going to code the policies, policy collection, and finally validation. We store everything in Airtable. In part because it allows us to store the PDF of the policy itself while we tag and analyze the policies. We use a data structure that includes subtopics, status, a brief justification, and as I mentioned, the actual source. And this is what it tends to look like. Essentially, what does each country have? In most cases, there are multiple laws, policies, and regulations per topic. It's often found in disparate areas of governance. But again, you'll see that the text itself is included, so you can, again, go back and do your own natural language processing. And then we work as a team to visualize the data structure. Again, we might be moving away from this if I can figure out how to use some other tools to do it. But this is what it tends to look like if you're, again, playing along online. And the data structure allows us not only to dig in on a topic, but also to see across the entire policy environment for a jurisdiction. So this is super helpful in emerging event. If something happens in, say, Kigali, like, say, a Marburg outbreak, you can see all the laws, regulations, and policies that might be on the books that might be relevant all in one place. So I will quickly show you some of the stuff we've done. The team's coded vaccination policies and policies for childhood vaccine in every country, captures requirements, enforcement mechanisms, exemptions, emergency measures, and also the specific childhood vaccines for different diseases. And you can dig in a bit on, say, enforcement mechanisms. Is it a fine? Is it threat of jail time? Is it exclusion from school? Are there multiple mechanisms at play? And once you know that, you can start to look at these enforcement mechanisms in detail, right? Is it a $5 fine? Is that sufficient to actually incentivize action? And then is it even implemented? Because it's something that's on the books, but it's so little that nobody even cares anymore. And if it is, does it actually change vaccination rates? And if it isn't effective, is that because $5 isn't enough to incentivize action? So we've started to play with this a little bit. We've also looked specifically at different childhood vaccines, so looking at measles, polio, diphtheria, TB, chickenpox, And you can then find yourself asking, staring at these maps a lot, and which we do, asking questions like, why one country requires measles and TB and another doesn't? Is it due to burden of disease? Are there other pressures? Does the disease does the policy correlate with burden of disease? Sometimes it does, sometimes it doesn't. Again, we've looked at AMR WASH policies. This shows policies for water quality, wastewater disposal, water monitoring, sewage, pollutant disposal, medical waste. Oh, there's a lot of stuff, right? So it's all in there. And a lot of countries have legally enforceable policies, but very few actually implement. So now we need to go, and there's a whole other research project there on figuring out which of these policies have actually been implemented and how. We've just submitted a manuscript on Tuesday looking at the role of militaries in outbreak response. Most countries in the world use their militaries one way or another during the pandemic, whether it was for logistics, vaccine delivery, maintaining lockdowns, or some other aspect of social order. We wanted to figure out what each country actually had on the books and how they could use their militaries domestically, including whether that was is that something that's embedded, codified in their constitution, who gets to say you can use a military and when, and the hypothesis being, is there a correlation between the authorities a military is granted and outcomes? What do you mean by outcomes? So if it's codified in your constitution that you can use your military in military operations other than war, which would include like the public health response, does that mean you exercise? Because militaries exercise when they have something they're supposed to do. And if you exercise, does that mean you have better outcomes? Does that mean you have better reduced morbidity and mortality where you use your military, or better efforts in trusting government or in maintaining stability? So all those questions yet to be answered. We have looked at the third rail of global health security, which is something called access and benefit sharing, in trying to figure out, even though it's a big topic in the IHR and the IMB negotiations, what does every country have? And it is literally the hottest topic in global governance of disease, but it relies on implementing legislation. And nobody's ever actually looked at what's there. So we went and we examined every policy at the national level, including scope, whether there was a specific policy related to what's called either digital sequence information or global genetic sequence data, language governing access to genetic resources, prior informed consent. Again, really weedy, but really important, because it allows us to then ask these type of questions. So there's currently 74 countries that restrict access to pathogens, and there are 53 with obligations to share benefits, and there are 60 countries that have codified positions on DSI or GSD. But there's a lot of regional variation. So let's figure out what this actually means. I don't know yet. As I mentioned, we have looked at jurisdictional authority for quarantine and isolation. Does it matter? I'm going to go back to Rwanda again. Does it matter if the authority and the ability to quarantine and isolate sits with the mayor of Kigali or the president of Rwanda? And if I know that, can I now look at outcomes? We all talk about localization and public health, but are there better outcomes? Do the vulnerable populations fare better if it's the local level authority who has that, who does the quarantine? Again, I don't know yet, but I want to know. And finally, the question that I get every single time I talk about this is like, that's nice. Can't AI do that? I didn't know. I mean, I knew a little bit, right? Because people have been asking me that question for a long time. So actually, in the middle of the pandemic, Amazon offered to work with us pro bono for a couple of years to figure out if they could automate some of our data scraping. And the answer at that point, after again 2 years and Amazon doing this, was no. Like, you need a human in the loop. All right, I'm like, that's great. I still have a job. But what we did was, I was like, well, let's see. Because right now, when I say here's a topic,
that's a senior researcher and or postdoc spending 6 to 8 months digging in and finding every one of these policies and reading it and coding it. That's a lot of work. So what we did is we designed a study, and it's up in preprint right now, where we used one of these generative AI tools. And it took a lot of times. We had to come up with the right prompts to figure out, could AI actually do this? So we did it from a couple of different directions. And the answer was no, not yet. Maybe in a month. But it was really good at finding the policies in English. Pretty good in the US and Europe. It got really bad when it came to French, Arabic, Chinese, and particularly bad in the lowest income countries for whatever reason. But also it couldn't find so sometimes you have to dig and find these policies. It sometimes sits in a place that you might find unconventional. And it wasn't great at finding that. But it wasn't bad. So what we're doing now is we're using these generative AI tools for QA/QC. So once we finish a topic, we then have a separate individual go and spend 1 to 2 months right now we're using Perplexity AI to test, to figure it out. I will say in the experiment we ran with 2 of our topics, AI found 3 policies total that we hadn't surfaced. Okay, well, it's checking our work. And again, I expect it to get better over time. And the other thing I'm going to try to figure out is, can I also ask AI to, here's my data set, can you make me this pretty map? So that I don't have to pay for the Amazon server space for those maps. So again, we're playing with it, and we're going to see how far we can get, and we'll keep updating it as we go. We also had to teach it not to spit back work that we did. So you have to play with it a lot. So where are we now? We've got a whole bunch more policies that we're hoping to look at. Really would like to add some subnational. We've got to then figure out, again, that framework, what's implemented, what's working. And as I mentioned, there is an insane amount of data that if anybody wants to analyze it, send me a note to let me know you did it, and we'll highlight your work. There's just so much stuff out there. But I'm really hopeful that we can actually start to answer some of those research questions so we can, again, provide better evidence-informed decision-making. None of this happens alone. I was looking at this slide as I walked in and realized that I left off my costing guru, so that's Stefina, so she gets a separate shout-out because she's not on the list. But there's been a large team that's been trying to do all this work. Oh, and I'm tired of talking. So I think now Claire's going to make sure I get a lot of hard questions, and she's going to tell me I'm wrong on everything. But really, thank you for the opportunity to share all this with you.
Thank you so much, Rebecca. Do you want to come and sit down? Do you want to stay standing up?
Oh, no, I'm going to sit.
I've been writing down so many different.
Some water.
I've been writing down so many different research questions. There's just such a wealth of policy data that you presented there, and you've highlighted some of the questions you've been looking and answering at. But I hope the students in the room pick up on this big flag of amazing data set that's available. I'm going to take my prerogative to just ask you 2 quick questions to start off the session. I have a lot more questions, but we can discuss those another time. The first thing that sprung to mind when you were looking at that policy data, right, and you were talking about how you can then provide this evidence base to show what works, right? Like, does it matter if the power is vested for putting a quarantine order down in a president or in a mayor, right? And that's obviously really useful data to have from a kind of legal or policy standpoint.
Thank you, because most people don't agree with that, but yeah.
No, but I guess I want to push you a bit and say, how can you then how can your data set then consider that in the political context, right? Because you can have a policy, but then actually, the president changes and actually an outbreak happens and the president decides, I'm going to do something different, and I guess how are you able, have you been thinking about how you can incorporate both political decision making and partisan decision making and just kind of political dynamics and how they change and like what's going to work, what's not going to work, beyond the policy. And then if I can ask you a perhaps trickier question.
Oh, because that one's not tricky.
Yeah. And if you don't want to answer this, you don't have to. But when you first started talking and you were showing the kind of, this is what's happening at the global stage, and, I know you have been doing a lot of work with the State Department, making a lot of that global level happen stuff. And then you presented the stark reality of the lack of it happening domestically. And I guess I want to ask you, how does the US have this double face, right? They're doing so much internationally on global health security and yet kind of can't get their ducks aligned domestically. So just two easy questions before we open up to the audience.
Let me give two completely non-satisfactory answers. Now I've got multiple mics. Okay. I think on the how does politics and how does the reality of a political environment play in? Yes, of course, right? You can't answer everything, so I think there are some ways that we can look at things like that. So, like in the military work, if something's codified in a constitution, that's very different than a bill that might have been passed, overnight and can be, with that's not funded. So that's one of the things we look at, and then we can study it, right? And you can study, how things are implemented or not, or whether there's actually resources that are then devoted by a decision maker to the thing. So there's no perfect answer. And this goes back to the notion that I think of what we're doing here as denominator data. It's a starting point, which then we can start asking some of those questions. It's not a great answer, but maybe we can come back to it. Your question of, why is the U.S. so screwed up? I wrote a paper, I published a paper in 2002, something like that. No, right around 2001, 2002, on public health and national security in the U.S., which is still a debate that's happening. And in that, I had a throwaway line around, public health, local public health is so under-resourced, we're still using fax machines. Well, you know what was happening at the beginning of the pandemic in the United States? We were using fax machines. It's literally the only part of the U.S., of government that uses fax machines. There was a dialogue during Ebola response in North Kivu, people deploying and saying, these folks, we have to use our epi-line data, we're handwriting it. I'm like, we handwrite our epi-line data in the US. So there is this kind, and I would sit in these meetings with in the pandemic fund where we have the privilege of reading every country's application for what they want to do to strengthen their core capacity. And I'm the only American on this group. And it was not uncommon for somebody to lean over and be like, as we're looking at lower income countries' proposal, and say the U.S. can't even do that. I'm like, you're right. The U.S. This is real. So I think that there is kind of this really weird disconnect between the efforts that are being put into helping the world build global capacities, sustained global capacities, engaging in negotiations, saying things like One Health is important, and then we've got H5. Jurisdictionally, like we can't even test the cows. Like there's some really structurally very complicated stuff that's going on in the U.S. And I have no great answer, but I will say that in the last year I've actually pivoted a lot of my work to we're still coding the world. We will create all the policies. We'll map all this stuff, but we've actually started to do a lot more work on domestic capacity building and particularly in the legal and regulatory barriers that exist.
I'm just the chair here, but can I answer the second question at least? Because it's not just health. And you would get the same answer across the board. The U.S. has done more internationally on climate than it's done domestically on climate, on almost everything. And it's a straight up constitutional question, which is the authority of the president and the executive branch in international affairs is just vastly larger with many fewer constraints than anything the executive can do domestically, where you get stuck with 50 states, all with their own politics, and where everything's bogged down. So it's a pervasive problem across U.S. government.
And public health is a police power delineated to the states under the Constitution, which means that there really is very little authority that's codified for the federal government to act on public health issues.
Okay, we're going to open it up. I'm going to take 3 questions at a time. We've got some amazing helpers with their roving mics. Please put your hand up, and as Larry said at the beginning, please tell us who you are and where you're from before you ask your question. So we're going to go right at the back first.
Hi, I'm Daniel Sutsatai from the Department of Health Policy. I'm a PhD student. Thanks, first of all, for the very insightful lecture. My question is kind of thinking back in 2019, I remember the Nuclear Threat Initiative, and I think it was Johns Hopkins at the time, had this global health security index published, where they ranked countries on the basis of like prevention, early response, detection. And at the time they ranked the US #1 and the UK #2. And then fast forward a year later, COVID started, and then we saw from even just the mortality rates that the US and the UK maybe were not as well prepared. So I guess my question is there value in trying to rank countries, or is there more of a danger, maybe perhaps from a behavioral point of view, in kind of making countries perhaps overconfident or complacent in their response because you're ranking a country and comparing them to others? Thank you.
Great, and then there was a question here. Pretty similar. All right, 2 for 1 question. Mark at the front.
I'm so sorry, may I get through, please? Thanks.
Hello, so I'm Mark Eccleston-Turner from King's College. My question, I completely agree. I think I'm nowhere near as optimistic about the
Are you
treaty.
saying you agree with everything I've
Yeah,
said?
but yeah, everything.
That's what I like to hear.
I definitely agree with the lack of optimism around the treaty, the pandemic treaty. My question is therefore, what happens next? What are the implications for that? Either for sort of like the global, the regional, but what happens if we fail in this sort of global endeavor? Thank you.
Great, and there was another. You had your hand up just here, and then we'll pass over back to Rebecca.
Hi, here Martina from Oxford University. I'm formerly working in Argentina. Well, in pandemics, I was working in Argentina and previously in the Argentinian Directorate of Epidemiology, and I worked with the international health regulations in a daily basis, like sending reports and looking for people with measles in planes and stuff like that. And the thing is that when COVID-19 arrived, that didn't work. And the international health regulations crumbled, and the nationalism was really an important thing. So, and I think I wanted to ask you, in terms of applying and rethinking international health regulations, what do you think about the role of the WHO and the capacity of the governing capacity the international organizations have to think about a real international regulation where countries can, well, face together next threat?
3 more easy questions for you, Rebecca.
Yeah. Well, 2 and 3 are linked. Kind of. Let me take GHSI. I'm now, am I loud?
You're fine.
Okay. So the question about the Global Health Security Index, right, so NTI and Hopkins put that out in 2019, another one in 2021. It incorporates, there's a lot of factors that go into it, but incorporates things like the JE, but they kind of made a name for themselves because they ranked countries. Most of the scholarship that came out during and after the pandemic found almost no correlation between the index and how countries did in the pandemic. In fact, the only things that really were popping up on correlations were kind of trust in government issues, corruption, negatively. So that raised a bunch of questions about the metrics themselves. The scholars who worked on that doubled down and said, we didn't mean to measure response. We were trying to measure different stuff. I'm like, well, that's, I'm friends and colleagues, but that was kind of a crappy answer. I think they could have used that as the opportunity to really think very creatively and thoughtfully around what are we actually measuring and why. But to your question, when they rank ordered countries, WHO was pretty unhappy about that when they did that and pushed back a lot. I don't know the right answer. I don't know if rank ordering, if that's good or bad. I mean, if you really wanted to figure out, you could be like, well, I'm a 5 and you're a 4. I mean, you could figure that out using other metrics. But I will say I don't love that index, right? So rank order or not, I think there was a lot of misconception about what those numbers said and what they didn't say. That's, and then happy to go line by line with you on what parts of the indicators I like and don't like. I'm in a room with people who read the footnotes. When you read the footnotes, you're like, wait a second, they put that in their model, right? And you're like, well, yeah, but we're the only people that read them. So that's index. Question about the implications for whether the treaty falls apart. The reason I'm going to combine it with your question is there are broader questions at play here around the future of multilateralism. It's not going great. And I'm not sure what's happening in Geneva is helping matters. I think it may be hurting matters. And what I imagine, what we are seeing happening now is a lot of countries looked around and said, the global system did me no favors during the pandemic. I didn't get vaccine. I didn't get the support that I was hoping to get. And so what you're having is a lot of countries that are saying, well, maybe I trust my neighbor more. And that's where you're seeing the rise of the regional public health institutes. You're seeing regional agreements that are being put into place. You're seeing, MOUs between countries on how they're going to support each other. Whether that's the thing that should be happening or not, I'm not going to answer. But it is what is happening. And some weird connections of countries that are kind of going in together, even if they're not geographically co-located. And I think that's the same answer, right? Countries don't trust that. Bigger to your point is, you can have a treaty, you can have everybody sign on to it, but countries are still sovereign. And at the end of the day, I mean, this gets into like whether we think international law is a real thing or not, right? But it's, you can have these kind of agreements, but it's why we've been focused on implementing legislation. You can sign all sorts of stuff, but like, how are you actually implementing it? And that's why we're keen on looking at that national and subnational.
Fabulous. I think we're going to take a few questions online. Andrew, if you can
Okay.
pose these ones.
Thanks very much, and thanks very much indeed, Rebecca. There's quite a few questions come in, so I apologise if we haven't picked yours. I'll just ask 3 quick ones. So this one came from Golmira. Are there plans to make your resources available in languages other than English? The second question's from Parisa, who's a former student of ours from India. What governance arrangements do you think are needed to overcome the inequity we often see when medicines, vaccines, protective equipment and so on get captured by wealthy countries? And the final question, also from a former student, Dolores, who's in Peru. Suppose there are indications of an emerging pandemic. What single crucial piece of advice would you give to a senior politician? Simple questions, right? Thanks very much to the online audience for those.
Wow. So the easiest one first. Are our data available in other languages or plans to do so? I believe our outdated costing tool online is available in French as well as English, but nobody should use that because they should just be downloading the spreadsheets. No, I run a externally funded research center, and we don't have any more money because nobody cares about this stuff anymore. So if somebody knows somebody who wants to invest in translating, fantastic. In the absence of that, I would do what we do when we're trying to identify policies and legislation, which is use Google Translate. It's pretty good at it.
That may be one thing AI can do for you pretty quickly, pretty cheap.
Yeah. So, yeah. Inequity of medical countermeasures. So I mentioned, access and benefit sharing as the third rail of global health security, and this is that's the question, right? So countries in the international negotiations is also tied into the international health regulations. It is all, and the questions about the future of multilateralism seem to all at this point be tied to the difference between saying we believe in equity and operationalizing equity. And operationalizing equity means you got to give people stuff, and that costs money. And so that is the core of access and benefit sharing right now. There are proposals that WHO has put forward. There's a proposal within the INB treaty negotiations for a new international system to make it more equitable. But honestly, those proposals are not going very far, very fast. There's a lot of problems with them. And if there is some language on a treaty that gets put forward in this year, it's only going to be because they're going to kick access and benefit sharing down the road. And that'll go into like a separate protocol. Because the last time the international community came together to try to negotiate something like that was under the Pandemic Influenza Preparedness Framework, PIP, and that took 4 years, and we ended up with an agreement that has more holes than solutions. So that's my answer on that. Which is, again, why we're seeing more countries go in regionally as opposed to globally, because they don't trust the issues around equity. The last one, what's a single piece of advice? There is no good answer on that, in part because if you've seen one outbreak, you've seen one outbreak. That being said, the basic theoretical framework in any outbreak is The faster you detect, the faster you respond, the more lives you save. You draw the epi curve. It's literally it's as close as we get to any main theoretical framework. So act fast. Yeah.
Sorry.
Oh, you're on. You now have to give a lecture on epidemiology.
Oh, I didn't. I guess we are drawing to a close, which is too bad because I've enjoyed this. I hope you've all enjoyed and learned as much from it as I did. Thank you so much. First, some other thank yous to Andrew, to Claire, to the people in the department who helped produce this event, but most of all, Rebecca, to you for coming and sharing all of that with us. So we'll join you and thank you. And before you do that, if you're interested, join us also for a drinks reception up on the 5th floor in the senior dining room. So with that, thank you for the evening.
Thank you. Thank you all.